might not remember Dr. Michael Abraham. Has anyone seen him before? Couple people? Yeah, great. So Dr. Abraham is amazing. He's a jack of all trades. He does a lot of different things. I'll let you let him tell you about his role at our hospital. He's a neurointerventional radiologist as well as a neurointensivist, and he has a lot of letters to make his name too. So please welcome Dr. Michael Abraham. I'm going to show you his neurointerventional surgery.
Good morning, everyone. Thanks, Sarah, for the introduction. I'm going to sit down so I don't block anybody here. But thanks for having me out here. I think it's been 4 years, pre-pandemic, when I last came out here to show off some of our toys, but I bought some new ones, so we can pass them around and you can see. But before I begin, I think this place is amazing. I think the fact that you all are here, partaking in these activities, working with these great people, is just really good. I refer a lot of patients to the American Stroke Foundation for continued therapy. So kudos to everybody here. So without further ado, and please feel free to ask questions at any time throughout this talk. We're going to talk about kind of what happens in the angiography suite, and I'll get to show you some of the toys that we get to use. So when we talk about what I do is what we call endovascular therapy. Basically, that just means inside the blood vessels. Everything we do is minimally invasive, where we run these catheters, these long tubes, similar to this, going either from the large artery in the top of your leg, as you can see in this diagram there. Additionally, and then we run these catheters under X-ray guidance into the head and the brain, and you can actually go to any part of the body, from down in the chest, abdomen, the leg, arm, but my focus is in the brain. We also are starting to come into the wrist as well. People tend to like that after they can get up after a procedure, they're not going to be flat for 2 or 6 hours. But again, everything is inside the blood vessel. So there's a small incision at the top of the leg or at the wrist. This is what an angiography suite looks like. We see 2 different scenarios. We see the patient laying covered in fluid, and we have 2 X-ray machines which we can activate one or both of them to see in real time these devices, these catheters going through the arteries or the veins into the brain. This is a picture of the angiography suite without anything there, but you can see the table there, the X-ray machine above right here and one to the side here. So it gives us a 2D picture of what's going on in the brain. So this field actually started in the early 1900s in Lisbon. There was a neurologist there, and this was some of the very first pictures of the blood vessel taken in 1927. You can see the skull here, and you can see these arteries kind of faintly, and this was done in 1927. So we've come a long way, you know, in nearly the 100 years these images were taken. This is an example of blood vessels now that we see. You can see how much crisper and clearer the arteries are in the brain. And with being able to see the arteries better, we can do more things endovascularly inside the blood vessel. So the thing I'll focus on today is stroke. So there's 2 types of stroke. There's what we call the ischemic, which is where you have a blocked artery, a blocked blood vessel, and if it blocks the arteries, it stops the blood flow to the brain, it can cause a stroke. As my older son likes to say, it's like getting a piece of candy stuck in your artery. So you can think of it that way as well. But the other type is the hemorrhage, where you have a blood vessel or an aneurysm that ruptures and bleeds inside the brain. And that's a smaller percent of all strokes that we see. And these pictures here just show the different types. On the left, we see a hemorrhagic stroke where an artery has ruptured in the brain, and you can see the blood pooling around. And then this picture on the right shows a blocked artery, and you can see the brain area that is dark there is the tissue that's stroked out. So when people come in with an ischemic stroke of blocked artery, we're trying to get that blood vessel open as quickly as possible. Every minute literally counts. So we're going to start with ischemic stroke. And you may have heard this term, time is brain. So every minute there's a little blocked artery in the brain, which can cause about 2 million brain cells to die. And that's a really fancy figure, but when you translate that to real life, basically every 30 minutes of decreased time, Basically, the faster every 20 minutes we can speed up the process, people can gain 3 months of disability-free life. So it's a very emergent situation that we're dealing with, trying to get these arteries open. So now we'll focus on the different treatments. So we'll take it way back to what I call the Stone Age, where the only treatment was aspirin. Before any of the other medications we gave or these tools, people would come in with a stroke and all they could really give was aspirin. And that was really to prevent a future stroke. It didn't do much for the current stroke that was happening. So that's been around forever. Then in 1995, there's a big study that looked at medication we call a clot buster. It's called PPA. And that's been around since 1995. We can technically give it up to 4.5 hours, but ideally, the quicker you can get it into a person, the better, because it ideally opens up a blood vessel. A newer type of clot buster agent is called tenecteplase, which you started using at KU in the last couple of years. It works a little bit faster than the TPA, but both of those can just go through a regular IV in your lung. So these are still the first lines of treatment for somebody who comes in with an ischemic stroke. And now we'll move on to the endovascular side of things, where we take these catheters into the brain to try to open it up. So this procedure, we can actually do up to 24 hours from the onset of symptoms. That's close to the 4.5 hour time limit for the clot buster medications. And even in some patients, we'll treat past 24 hours if their brain imaging looks favorable. So the broad age of this type of treatment, the first treatment that came out was about 15, 20 years ago, called the Mercy device. It was basically a wire that was shaped like a corkscrew. You can see on this picture here, we would take it into the brain and into the clot and literally try to pull it out. So this was the first clot retrieval device that was developed out there. So everyone was very excited about it. It was a great step in the right direction. But since then, much more advanced techniques and tools have been developed. So we've come to the golden age of treatment here. So the first one is what we call aspiration thrombectomy. So this is where we take a catheter, like you can see in that picture, and we take it literally to the brain, to the clot, and we suck it out. And I'm going to pass around a device. You can all take a look at it. Promise it's not been in somebody's brain, but you can feel how soft it is. But we can get this into the brain, and thanks, Sarah. And then we hook it up to this what we call aspiration tubing, and this connects to something like you see in the picture, that white tank there that sucks up the clot. And we have a little switch here. I can turn the suction on or off, basically, and that ideally pulls out the clot. So this was a big game changer. This is back around 2008, where this type of technology was first developed. And then since then, the engineers have gotten very fancy and have made a whole slew of different types of catheters that are soft enough so that we don't damage the artery. They're big enough so we can try to take out the whole clot in one fell swoop. So there's multiple different catheters out there now that we have. Then the other thing we have is something called a stent retrieve. So as some of you may know, a stent is just a hollow mesh tube that we can go and put inside people's arteries or veins to open them up. But what this type of device does, it expands into the clot, as you can see in these pictures. And while it's expanding in the clot, it's kind of becoming one when the clot are integrated. And we leave it open for about 4 to 5 minutes, and then we pull it out. So I'm going to pass this device out as well. Yeah, so when we open up these stent retrievers, it takes about 4 to 5 minutes to fully engage into the clot. So we leave it open, and after 4 to 5 minutes, we slowly pull it out of the brain, ideally with the clot intact. So this standard retriever that we're passing around, there's actually, it's a little bit different than the traditional ones we have. Feel free to play with the handle. You can actually expand it or decrease it, and that's what we do when we get it to the clot in the brain. We expand it just enough so that it again captures the clot without damaging the artery. So these two are kind of the mainstay of what we have was endovascular clot treatment. And they have been very beneficial for us, for patients, because now we can actually get into the clot, pull it out, what we call one pass, get all the clot out. So it's really changed the way we treat stroke. And similar to the aspiration catheters, several companies have all kinds of different stent retrievers. These are just 4 of them. There's probably 10 of them around the world, different types. They all are very similar, but have some minor differences. So this is an example of a patient I treated a few years back, 52-year-old female, presented with left-sided paralysis. She had AFib, so atrial fibrillation and irregular heart rhythm. Very common cause of strokes. The first line of treatment is being on the blood thinner. Here is her CAT scan. So this is us looking straight at her head. So because of that, this is the right side of her brain, this is the left side. And what we can see here in that circle is she has a clot at the top of her carotid artery. So the carotid artery supplies, the right one supplies the right front of the brain. So she basically has severely diminished flow to that side of the brain. So here's the actual angiogram. So I went into her arteries, and you can see the contrast side filling the carotid artery, but you see no blood flow past this area. Normally, this should be filled with arteries, but we don't see it because there's a clot there. So I went in with a stent retriever. You can see the stent retriever sitting inside that artery and slowly expanding, integrating with the clot. And then afterwards, now the clot used to be here, but now we see complete blood flow back into that area of the brain. And then additionally, you can see the clot. This is what we pulled out of the brain, and this is 20 millimeters long. So 20 millimeters is not a very big size, but in the brain, it's a very large size. So that can cause severe damage like this. So this is the goal when somebody comes with a stroke. We want to get that all those arteries open as quickly as possible. And then one of the things a lot of people ask me is when you're going up and you pull this clot out, and you're pulling it out, do you worry about pieces breaking off and showering with the rest of the brain? And yes, that can happen. But one way we try to avoid that is using something called the balloon guide catheter. So if we look at this picture here, we usually have a bigger catheter sitting lower down in the neck, and they can have a balloon at the tip. And when we're pulling out the clot, we'll inflate the balloon. So you stop all the blood flow from going forward. So if any clots are going to break off a major clot, that ideally avoids that. And I can show you a picture. This is a patient I treated actually not too long ago. But this video, this is a magnet video of this picture, but you can see the balloon inflating right here. In a second there. So you can see it, so we inflate it. I'll pass this around as well. And I have a syringe connected to it. And feel free to play around with inflating the balloon. You can feel it, but that's what we put in the neck to basically with a little syringe in it. And there's a white syringe that's attached to it. So we just inflate it, put a couple cc's of air, and it opens it up. And then we keep it open just for the amount of time that it takes to pull the device out of the clot. So only less than a minute to keep it inflated. So that's another technique we have to treat strokes. And then sometimes, I said atrial fibrillation is a very common cause of strokes because clots involved in the heart. Sometimes people can have severe disease in their carotid arteries, meaning a lot of plaque. So this is a young guy we had several years ago, came with some mild strokes with slurred speech, left side of weakness. Here's the MRI of his brain. These little white dots are tiny little clots that have broken off and what we call showered into his brain. So his cause of his strokes was actually right here, what we see here. These are a few views of his carotid artery, but you can see how it's severely narrow right there. Right there. So it was just due to severe atherosclerotic plaque. He smoked, he drank, did drugs, very bad lifestyle, which led to this at the young age. So in his case, we knew we had to fix this carotid artery. We had to open it up for two reasons. One, some more plaque doesn't break off and go to cause more strokes. And then two, there's a risk that this artery can completely just shut down and block right here. So in his case, I went in and I did balloon angioplasty. You can see a balloon sitting right there. And then the other thing is when we're angioplasty all this plaque, the other question we worry about plaque breaking off, going into the, breaking off more strokes. So one thing we can do is take essentially like a net called a distal protection device, but you can see it looks like this, and there it is, carotid artery. So it sits up higher in the carotid artery and it basically catches any debris from going into the brain while we're doing the angioplasty and putting the stent there. So you can see now the carotid artery looks much bigger after the angioplasty. And then I went through and you can see the stent right there. It's a hollow mesh tube, but now the artery looks completely normal. So this guy, after his first stroke, made, big lifestyle changes, cut out the smoking, cut out the fast food and things. So he's, back to normal things. So those are probably the two very common causes of strokes that we see at the hospital. Yes.
So, you're talking brand new pieces, little lots.
Yeah.
How do you get to those?
Yeah.
Anyway, you're talking.
So these was where he first came to the hospital, he had all that plaque in the carotid artery, and some of it broke off and went really far out into his brain. So these types of clots we wouldn't go after because they're really small vessels on the order of 1 millimeter. They're too dangerous to try to go pull a clot out. But this type of stroke would be good, nicely treated with the clot buster medications given to the IV. Mhm. Yeah. Yeah, that net, and then we take that net out when we're done with all the procedure, yeah, but it stays in there and catches any debris, kind of as you can see in this picture here. Yeah. And then after stroke, as you all know, there's rehab, inpatient rehab, outpatient rehab, and then outside of that, there's just the other things that are good for life, exercise, I talk about these things when I see patients in the clinic of stroke, what are you doing for fun outside of stroke? Ideally getting outside, socializing, all these things are good for rehab after a stroke. And then stroke outreach groups like we have here today. All right, so now we're going to move on to hemorrhagic strokes, specifically ruptured brain aneurysms. So when people present with a ruptured brain aneurysm, the most common presenting symptom, we call it thunderclap headache. It's a very severe headache, it comes on very quick, very fast. People frequently have nausea, vomiting, and sometimes they may lose consciousness as well. And bleeds are much different than the ischemic stroke in that they have a very higher mortality rate. So with ruptured brain aneurysms, about 30 to 40% of people don't make it to the hospital alive, or they're in very, very poor state of the country. So when people come in with a brain aneurysm, we need to stop the blood from going back into the aneurysm. So there's two types: one, the endovascular approach, and the other is clipping. So this schematic here just shows a typical brain aneurysm. The other name is called a berry aneurysm. In the early days of medicine, physicians would name things in the body based on what they see in nature. So basically it looked like a berry off the tree. So that's why it's called a berry aneurysm. And most of them are roughly at the level of the eye. So at this level, somewhere in the brain, where most aneurysms come on. And this picture shows an aneurysm that is ruptured. So when an aneurysm ruptures, the body tries to stop the bleeding. Just like if you were to cut your hand, it starts to form a plug there to stop it. But it's obviously more serious than a bigger cut. So we need to try to fix it. With brain aneurysms, they're not as emergent as ischemic strokes, meaning where you get the blood vessel open. With these, we like to treat roughly the first 12 to 18 hours when you're trying to come in. So the whole goal is, if this is a brain aneurysm, we need to stop the blood flow from going into the cellular black circle to initiate stopping blood flow. So one way is, it's on the next slide, is clipping. That's an open surgery where one of my neurosurgery colleagues will go through the skull and put a titanium clip at the base or the neck of the aneurysm, and that's not the blood flow going through there. But if we can treat aneurysms the endovascular way, there's small incisions, that's generally the preferred method. Because, we get to avoid having an open surgery. So aneurysms come in various sizes and shapes. This one here, this is that very aneurysm or saccular aneurysm, probably the most common. Sometimes they have a very wide neck, meaning the origin of the aneurysm is very wide. And sometimes they're shaped like this, where rather than being like a sac, it encompasses the whole artery. We call it fusiform aneurysm. So treatment options, these kind of sum it up on these pictures here. This is the clipping procedure where you see this titanium clip at the base or the neck of the aneurysm. And then the coiling procedure is where we take these coils into the aneurysm. So this is a nice schematic showing it. We take a small catheter that's about 2 millimeters into the aneurysm, and we fill aneurysms up with coils. I have a flow model here, but the camera's not working, but I'll pass them on for you here. So Sarah's going to pass around foil. They're for the most part made out of platinum, but they're very soft. They come in various sizes and shapes based on what the aneurysm looks like, how big the aneurysm is. So we choose, we typically start with a larger coil, builds in a lot of the aneurysm, and then each coil after that is a little bit smaller and shorter. Sometimes we have to use a stent that would stay in the main artery just to keep the coils in there. And then sometimes we also have to use a balloon just to keep the coils in there, but the balloon typically comes out when the case is done. And then in some aneurysms, when they're really large, like they're 12 millimeters or bigger, we can put something called a flow diverting stent. So this schematic here just shows blood going into an aneurysm, goes into and out. And by putting a flow diverting stent, it has a lot of metal in it. And what that does is it diverts the blood flow away from the aneurysm. And eventually the aneurysm shrinks off. So these have been, big developments in the treatment of minimally invasively treating aneurysms. Let's see if this video works good. So this is a nice video. Hopefully it won't go. So this is actually showing, how catheters go in through the artery. You can see them part here. But we take these catheters, like you can see there, and we engage or advance them into the brain arteries. I'll fast forward a little bit so we can see the aneurysm. So you can see actual catheters and wires going through here. So a lot of times we get these nice 3D pictures of aneurysms, and that helps us really study it to understand, its true shape and size, and that helps us decide the best way to treat these aneurysms, whether we do it through a small incision or open surgery. And then now you can see the aneurysm here. So when we get into it, we're taking a wire that is 0.14 of an inch into there. So very small, very soft, because we don't want to dig anything too big in there because there's always a risk getting into an aneurysm of popping in and causing a bleed again. So here now you can see the wire going slowly into there, and there's a small catheter going over there. So the catheter stays in the aneurysm throughout the whole case, and that's again 2 millimeters or so. And soon you'll see a coil coming through here. And again, these coils are very soft. off, and you can see it starting to take the shape of the aneurysm. And what Sarah's passing by, the typical coil that we would use. And here they inflated a balloon there just to keep the coils in the aneurysm, because sometimes they can pop out. So now the balloon right here is inflated. And now that coil is so soft, we keep advancing it, it takes the shape of the aneurysm. And some of them are designed in a 3D shape, some have what we call a helical shape. Those are the common shapes we have. Correct, yeah, so we get very accurate measurements of the aneurysm, and then the coils have a shape, an inherent shape to it, and those have a size to it. So based on the size of the aneurysm, I choose a coil that's the same size or very close to match it. So that first coil we put, think of it like a basket or a cage, it stays in there, and then all the subsequent coils are smaller and shorter, and they just kind of stay in the aneurysm. And now you can see, now this is after several coils have been placed into the aneurysm.
And what is the, like, what is the purpose?
So we want to block blood flow from going into the aneurysm. So by filling it up with these coils, it blocks the blood flow there. Yeah. Same way as if an aneurysm went flipping, where they put the flip at the neck, it's basically aneurysm that stops the blood flow. Yeah. But if you do it this way, it's too small, then as opposed to.
So those are the names are then.
Sure, they see that. That's that video. So this is, I'm gonna go over a couple cases. This was a young gal I treated a while back. Here's her CAT scan of her brain. And you can see some faint whiteness here. That's the blood from her ruptured aneurysm. And then here's her carotid artery, and you can see this aneurysm here. It's much different looking than the ones I showed you earlier, but it's very irregular looking. And you can see the little point there, that's probably the place where that aneurysm ruptured or blood from. That little tip right there, called a Murphy's point. So in her case, similar to that previous video, I had a balloon in her carotid artery just to keep the coils in there, and then you can see the coil mass in her aneurysm. And eventually, as more and more coils, there's no more filling in the aneurysm. This is another young female had that underhepatic infusion. Here's her CAT, and you can see her blood a little bit better than the previous scan. It's all this white stuff. So in her case, I looked at all her arteries from the get-go. She has this little small aneurysm right there. You can see the little blank. And then she had another aneurysm. You can see right there in her carotid artery. She had a third aneurysm on her right carotid artery and a fourth aneurysm on her heart rate back end. So she was a long time smoker, at least a pack a day, which probably contributed to all this. So when people come in with a ruptured brain aneurysm and they have multiple aneurysms, sometimes we don't always know which one bled. So in her case, I just decided to treat the two larger of them, just because we knew, typically the larger the size of the aneurysm, the higher the risk of bleeding. So I treated the right side, you can see the coils there. Afterwards, no more filling of that aneurysm, and then that one in the back of her brain, I put coils in there, again, no more aneurysm filling. So she's done very well. This was 5-6 years ago. I just see her on a yearly basis with an MRI scan to monitor this other brain aneurysms.
How long did it take to do that surgery?
Probably about 3 hours. So yeah.
You had 4 aneurysms?
I treated 2 of the 4, the 2 larger, yeah, but looking at all her arteries and treating both of them took about 3 hours or so. Sometimes they can take longer, it just depends the anatomy and of the aneurysm.
All of this requires some kind of incision.
Yeah, either going through the wrist, an artery here, or in the top, but just about this big of an incision, very small. Yeah.
So it was too dangerous to get on board?
When we look at aneurysms, if you look at this one, because it was so small, it was a very unlikely cause of bleeding. So we didn't go after that one. And I've been monitoring that, it's been the same size since. And then this other one that was hiding in a carotid artery. This is actually below the level of the brain, so sometimes we can see aneurysms below the level, like outside the skull, and those ones we don't worry about bleeding. But we sometimes people can have stroke from there, but so there, unless this grew, you know, to the order of like 15, 20 millimeters, it would be something you would treat, but it's been stable at around 6 millimeters or so.
What do you use to apply pressure to control the filament that you're putting in there?
Just the fingertips.
Just make-
Yeah, so just slowly advancing it, you know, a millimeter at a time. Because, you know, you saw those coils going in that video, because if you go too fast, you know, these aneurysms are very thin walls, so even coils can cause the aneurysm to bleed. So if you go very slow, making sure it's ideally taking the shape we want it to. And sometimes it involves advancing a lot of the coil, and if we don't like how it looks, we can pull it back out and then advance it again until we like what it looks like. And then once that coil's in there, at the back of that wire, we hook up a little handle and we press the button, and it actually cuts off the connection between the wire and the coil. So we pull that delivery wire out.
How long do you have to be in your field to actually perform procedures?
Yeah, so I did a 3-year training, so that's roughly about. Oh, yeah, I did 6 years med school, 4 years residency, and then 3 years of training, so we could do that. Yeah. A lot of school, but it's worth it. I love what I do. Yeah, good question. So yes, what is subarachnoid hemorrhage? So basically there's different membranes over the brain. And one layer is called the arachnoid membrane. So the subarachnoid space is the level below it. So that's where spinal fluid flows in our brain, in that subarachnoid space. You have subarachnoid. Yeah. So that's what it is. And when aneurysms bleed, the blood goes into the subarachnoid space. Yep. Good question.
The only thing they told me was it was a leak, not a normal stroke. Does that mean?
Yeah, so sometimes with brain aneurysms, people can have, you know, this a really bad headache for several days, and the aneurysm can just have a slow amount of blood come out like a leak. And then sometimes they start with a leak, and then like a week later, it's a full blown rupture. Yeah. So you just had a leak,
Yeah.
so that's good. Yeah. Yeah, still a hemorrhage, so.
And or they just get your blood level lower, is that what?
But now, did you have an aneurysm though?
That only, it wasn't the normal stroke, it was only.
Oh, leak, okay, well, then sometimes people can have brain hemorrhages not related to an aneurysm, where a small artery can actually just bleed. And a very common cause of that is uncontrolled high blood pressure.
Yeah.
So,
Yeah.
yeah, and that can happen with all different kinds of bleeds, whether it be from an aneurysm or just high blood pressure.
Yeah.
Did you?
Do you know what percentage of these, where they don't really know the cause of it? Because I never had a headache, I don't know, I didn't have an aneurysm.
Yeah, it's a smaller percent. I would say probably less than 10%. You know, we don't 100% know what caused a bleed in a patient. So, because most of the time, like the most common cause of any kind of bleed in the brain is uncontrolled high blood pressure. That's probably the most common thing we see, and then after that's probably brain aneurysms.
What if you never had high blood pressure? Never had.
That's true. I have had people with aneurysms who have never smoked, never had high blood pressure, very good lifestyle. And you know, we're still doing research into it because there also may be some kind of hereditary component as well. Or there may not be. People may just develop aneurysms for some other unlucky reason, unfortunately.
What's the percentage you don't determine on ischemic growth?
Yeah, I would say it's less than 10%. what we don't, we can't 100% say what caused the bleed.
I'm one of the ones that they can't say.
Still, nothing really. And they've done follow-up imaging after your initial bleed. And then you find it interesting. Yeah, there is one entity, it's called cerebral amyloid angiopathy, where you can have these proteins that get misfolded and they get deposited in some arteries that cause them to bleed. Now, the definitive diagnosis for that is a biopsy or autopsy, so we're not commonly doing that here. So, we all know that, so, and a lot of times it's either a probable or possible diagnosis, so if we rule out, all other causes, we may say it's possible or probable amyloid angiopathy.
Mostly.
Oh, you're waving her, okay. Yes.
After you've had a stroke, the person says an appointment to have them look at their brain and get me to nothing else going wrong.
Yeah, it's a good question. Yes, after a stroke, we do, follow-up imaging to make sure nothing's going on. So we don't do follow-up imaging in everybody, but if you have a carotid, if you have a stent placed somewhere, then I typically do a follow angiogram 6 months to check it out. And then I do yearly carotid ultrasounds to follow those things. And then with brain aneurysms, we also do follow angiograms after treatment to make sure that the aneurysm still looks treated. I'll show you a case where an aneurysm has regrown after treatment. Yeah.
And insurance cover that, and then somebody would have to pay out of their pocket.
With those things, I've never had an issue with insurance covering it. They usually cover, follow-up imaging and things, so. Which is good, I think, because we want to make sure that things still look good, because we don't want people to have more strokes or more bleeds.
Sure.
Yes,
It's like a pond bleed.
yeah, so the pons is a location of the brain that we call the brain stem. So the brain stem is right here in the neck, connects the brain to your spinal cord. There's 3 segments, there's the midbrain, the pons, and the medulla. So people can have bleeds in the pons. One of the most common causes is high blood pressure, unknown high blood pressure. Okay. Did they do follow MRI sometime later? Was it dedicated? Okay. If you can give your time and scenario, I would be happy to review it for you, just to take a look. There's some people have these things called cavernomas in the brain. They have anywhere in the body that we have in the brain. Sometimes those can bleed. I've seen people with cavernomas in the pons or brain stem that can bleed as well. But I'd be happy to review it. Kind of another pair of eyes on it. Well, the fact that you're here is really good, because typically pontoon strokes tend to have a much poorer outcome. Yeah, most people, like you said, don't make it out of pontoon stroke, because that brain stem is what carries all the information from the brain to the rest of your body and vice versa. So when you knock that out, then people are very well. You don't know that for me, so. All right, so we're gonna move on to another aneurysm case. So you can see this is, you can hopefully see this is a carotid artery, and you can see the patient has a very large aneurysm sitting here in the carotid artery. I think I have a zoom of you. So this is a very, very large aneurysm. So this is something I treated with one of those flow diverting stents, the one that has a lot of metal in it that diverts the blood flow away. So here's before treatment, and immediately after treatment, you just see a little bit of the aneurysm. So with all that,
That's big.
So I have a sending aortic connector.
You have it, is it, yeah, and people can have big aneurysms in the aorta as well, they can be treated with similar but larger types of stents that they block the blood flow from going into to the aneurysm. And this is the type of flow diverting stent we use, you can see there's a lot of metal in there. So one of the cooler, newer things we have is these things called the web device, stands for woven endovascular bridge, and I have a few, we can pass them around. Basically, this is a braided mesh. Thank you, Sarah. And it's either in a sphere or a cubical configuration. If an aneurysm is appropriate, we actually like to treat it with these things. So, because the nice thing is, it's kind of a one-stop shop. You go and put one of these devices in, and then you're out. Whereas compared to the coils, as I said earlier, somebody you put several coils in there. So these things, they come in varying sizes. I think 11 millimeters is the biggest one, but they're very nice. They're very soft, and they basically do the same thing. They block the blood from going into the aneurysm. So this is a guy I treated a few years ago, he had headaches, slurred speech. You can see he has a very large aneurysm in the back of his brain, right there. I think it's what, 16 by 13 millimeters, so very large. Yep, we put those in there, yeah. So in his case, I started filling the aneurysm with coils, you can see less filling. And eventually, you know, I treated the majority of the aneurysm. I had to leave the bottom part of it open because he had two arteries coming out of the aneurysm, so I didn't want to block it at all. So I did this follow-up angiogram. He regrew the aneurysm, as you can see here. So in his case, what I did was I went in and put one of those web devices, and you can kind of see it at the bottom of his aneurysm there. And then afterward, you see decreased blood flow there. So I'm very happy with that. They did a follow-up angiogram, and he regrew again, unfortunately. So you can see that. And I like to show that on the side view, it looks like maybe but so I just want to throw that out there inside there. So because it regrew again, I decided to treat it again. So in this case, I did something called stent coiling. So I took one stent from this artery to this artery, and then I took another stent through it, and the stent basically acts as a scaffold to keep the coils in there. So here is a picture just with the stent. You can see one stent going from here to here, and then the other going from there to there. And then afterwards, filled it up with coils, and it's no longer filling there. And that is all I have. These are my two little guys who keep me busy on that work. I'd be happy to take more questions.
If you don't know what the procedure was, what they had to do, where you had done it, did they keep a record of that?
Yeah, they should all be reported in the medical records. Yes.
Once you remove the clot, in a situation, does the cell return? Dead cells?
Yeah, so he has, once we remove a clot, do the cells regenerate new cells? Essentially, yeah. So there's a process called neuroplasticity, and that, you know, basically where those brain cells that have already stroked out typically don't do anything after that, but other cells around there start undergoing neuroplasticity to try to help and regain some of that function. And that's where things like this, rehab, therapies, all those things can help with that neuroplasticity. Yes.
How often when you remove a clot and it comes back? Was it the percentage?
Yeah, it's very well, like, as long as you figure out what caused it, it can be very low. In my 10 years in practicing KU, I've seen probably only 2 people who have come back. My partner had one and I had one. I treated a stroke on one side of the brain, and like within the week, they came back with a stroke on the other side. Yeah, and those were both due to a clot in the heart for atrial fibrillation. Yeah, so that's why we try to get people on blood thinners as soon and as safe as we can to prevent that from happening. So, but once we figure out the cause, it's typically very unlikely. Yes.
So the blood thinner does what?
So, when you have atrial fibrillation, you have four chambers of your heart, and they normally pump in a nice synchronous fashion, but with an atrial fibrillation, it's irregular contraction of the heart. So anytime you have irregular blood flowing, it can start, it's a high risk of forming clots in that area. So by being on a blood thinner, keeps your blood thinner, so that you don't form those clots in the heart. Yes.
I have a number of kids outside the heart,
Mhm.
and, do they ever just go and remove them? What happens to the stairs if it's in there long?
Yeah, it's a good question. What happens to the stents when they stay in forever? So what happens is if you're looking down your artery or vein, when we first put the stent in, it's just on the outside, but over about 6 months' time, a thin layer of the blood tissue of the blood vessel grows over it, so it becomes kind of one with your body. All right, well, thanks.